We all know as diabetes is a disease of overnutrition. Let's discuss about the undernutrition in diabetes. So, regarding this topic, we are here with this impact of undernutrition on the clinical outcome of diabetic patients. And let's malnutrition is refers to getting too much or too little of certain nutrients, and it can be classified as undernutrition or overnutrition. So what's undernutrition? It causes weight loss and fatigue, and there are some mineral and vitamin deficiencies which are attributed to undernutrition. And whereas overnutrition can lead to overweight, obesity, and inadequate micronutrient deficiencies. So American Society of Enteral and Parental Nutrition, it defined this malnutrition as an acute or subacute or chronic state of nutrition with in which there are varying degrees of undernutrition or overnutrition with or without inflammatory activity, and that have led to a composition change in the body composition and diminished function. And it can be both undernutrition and undernutrition. So as obesity has been recognized as a risk factor for diabetes, malnutrition has its potential effects in the development of insulin-dependent diabetes mellitus. And this WHO, it defined malnutrition as a clinical entity as malnutrition-related diabetes mellitus in 1985. So what is the classification of MRDM? It's of two subgroups. First is the fibrocalcific or fibrocalcous pancreatic diabetes, and second is PDDM, protein deficient pancreatic diabetes. So let's go with the case in our OPD. A 35-year-old male presented to OPD with history of polyuria, polydipsia, and weight loss, and he has a history of treatment for refractory chronic pancreatitis, for which the surgery was done. His blood sugars were 520 to 520, and HbA1c was 12.6. So we did an abdominal X-ray, and this was the X-ray. There was extensive pancreatic calcification in the X-ray, and we go with the diagnosis of fibrocalcific pancreatic diabetes. So the approach to fibrocalcific pancreatic diabetes is that whenever you see a patient, young, lean patient with diabetes, either it can be of acute onset or insidious onset. If there is no pancreatic calcification and the ketosis is positive, these patients usually respond to insulin, not to drugs. So we classify these patients as type 1 diabetes. But if the diabetes of insidious onset, there is pancreatic calcification, there is no ketosis, so these patients respond to insulin and sometimes to OHAs also. You classify these patients as fibrocalcific pancreatic diabetes. Let's go with the second case. There was a 40-year-old female, known case of hypertension, and was diagnosed as type 2 diabetes mellitus, was on oral medications, and presented to OPD with history of palpitations, weight loss, and loose stools. So she was bedridden for last 2 months, and with this complaint, she presented with hyperglycemias, and we started on insulin therapy, and she developed hypoglycemias. So she had she was severely malnourished with BMI of 13.5. So the X-ray abdomen was done, but it was normal. So it was done to rule out FCPD, but it was normal. So what was the likely diagnosis? It was possibly PDDM, protein deficient pancreatic diabetes, or also known as protein deficient diabetes mellitus. So some bit about this. So it is similar to FCPD, but there is absence of radiological or clinical dysfunction, pancreatic dysfunction. And they have a clinical feature of low BMI, and there are symptoms of malnutrition and growth retardation. You can see the patients with ketosis resistance because of subnormal beta cell function that leads to insulin interruption. And there is shrunken pancreas without calculi and without some polymorphic infiltration. In addition to, there are extensive fibrosis of the pancreas. And there is a deficiency of micronutrients which initiates the functional impairment of the pancreatic beta cells. So this article published in International Journal of Research and Review showed that malnutrition is related to deficient micronutrient and macronutrient, and maternal malnutrition during pregnancy is the rare risk factor in which causes decrease in the fetal intrauterine development and leads to insulin deficiency, glucose intolerance, and insulin resistance in the Indian population. So that's why there is an evidence-based individualized nutrition therapy in these patients. So how does this prenatal nutrition, malnutrition induce epigenetic dysregulation as a risk factor for type 2 diabetes mellitus? So this suboptimal maternal malnutrition is defined as a big risk factor along with this maternal nutrient restriction and gestation diabetes. So there is deranged cellular energy metabolism, glucose handling, lipid metabolism, and mitochondrial biogenesis, which leads to insulin resistance, hyperglycemia, hyperinsulinemia, cardiovascular deaths, and obesity. So in this diagram, you see that nutrition poor environment in pregnancy is defined as a biggest risk factor for the offsprings to have diabetes and to have malnutrition in the diabetes. So let's go with the IUGR-induced epigenetic changes, which was shown that maternal drug use, maternal alcohol use, maternal smoking, and prenatal stress, hypoxia, malnutrition, these are all the risk factors for IUGR-induced epigenetic changes which have led to type 2 diabetes in the offspring. This article published in International Journal of Nutrition, Metabolism, Health Sciences reveals that we should go for the must screening tools, like simple screening tools, to identify the nutrition status of patients in diabetes in OPD settings. So let's classify malnutrition. So it is of 3 types. First is the disease-related malnutrition with inflammation. Second is disease-related malnutrition without inflammation. And second is malnutrition without disease. So this disease-related malnutrition is divided into 2. Acute disease-related or chronic disease-related malnutrition, and this can be of cachexia, cancer cachexia malnutrition. And second, malnutrition or undernutrition without diabetes, it is of socioeconomic state, due to socioeconomic status and hunger-related malnutrition. And you can see this undernutrition composes of 25% of the patients, diabetic patients, who have tendency to go with diabetes in the future events. So one more article published in this Hindavi, it stated that the patients who had CKD with diabetes had highest risk factor of malnutrition and more chances of having death in the patients without diabetes. So this, whether type 1 diabetes is a resource poor setting or malnutrition related or malnutrition modified or just diabetes. So it's of 2 types, resource poor or Western. So you can see that resource poor are more associated with markers of undernutrition as compared to Western, which are associated with increased child growth. So associations of different. So in critically ill patients who have malnutrition, you can see that severely malnourished patients had higher longer duration of stay as compared to well-nourished patients, and as highest degree of malnutrition, and they were associated with higher mortalities. So you can see this graph. The well-nourished people were 16%, whereas moderately malnourished were 50% and severe were 34%. Well-nourished people had lower mortality, as well as severely malnourished had higher mortality, as 9 times more than the other people. So you can see that the malnutrition is associated with worse outcomes among hospitalized individuals with diabetes, and these patients have a longer duration of stay and 9 times higher risk of dying. So let's define what is sarcopenia and malnutrition. Both are different terms, and sarcopenia just overlaps with the malnutrition. And you must know that pre-sarcopenia is characterized by reduced muscle mass, but there is no reduction in muscle strength or physical performance. While as the sarcopenia is characterized by presence of low muscle mass along with low muscle function also. So there are few effects of sarcopenia on the body. There's increase in patient length of stay, there's decline of the daily activities, reduced day-to-day activities, increased risk of illness, poor wound healing, and increased mortality. This article published in the Progress in Nutrition 2018 showed that 1 in every 4 patients admitted with type 2 diabetes had malnutrition or had malnutrition risk as in patients if they are overweight. So malnutrition was more prevalent in the patients which were admitted with diabetes. So you can see that 1 in 3 patients, whenever they enter a hospital, they are malnourished. So this was another article published in BMJ. It showed that The ischemic heart disease, AMI, acute myocardial infarction, stroke, COPDs, all these events were more prevalent in patients with diabetes, and the hazard ratio was 1.62, 1.47, 1.59, and 1.66 respectively as compared to the hazard ratio in patients without diabetes. This Kaplan-Meier curve suggests that malnutrition in patients without diabetes, the half-life was 2.38, whereas the patients without diabetes, it was 5.08 years. So let's go about why there is malnutrition in diabetes. And you can see an article published by Jasbir S. Bajaj. And there was this non-insulin type 2 diabetes mellitus is associated with overnutrition. But yes, it's also associated with undernutrition. And that's why, because of high probability of tuberculosis among the diabetes, there is a need for doing chest X-ray in all patients with diabetes to rule out tuberculosis. And tuberculosis is a high risk factor for patients with insulin resistance. So there is one more term called malnutrition or obesity. So all these micronutrient deficiencies, they are the culprits in causing diabetes. And you can see that there are some specific multivitamins or some minerals which impair their roles in glucose metabolism and insulin signaling pathways, and they are the culprits in causing diabetes. So you can see thiamine, B12, vitamin D, chromium, and these are all the micronutrients which can promote diabetes in the later onsets. So you can see vitamin D leads to the prevalence of deficiency is 85 to 90% in both in obesity and type 2 diabetes mellitus. So these are various micronutrients. So whenever there are altered levels of zinc, chromium, selenium, calcium, boron, iodine, magnesium, iron, they lead to increased oxidative stress, lead to increased insulin resistance, and lead to diabetes. So what are the risk factors for the same? They are the genetic-induced risk factors at advancing age. Second are the modified risk factors like smoking, nutrition overload, nutrition deficiencies. Third is the maternal malnutrition. And fourth are the pediatric-induced factors, as I discussed in the previous slides, like poor growth development and low birth weight. This is a vicious cycle of micronutrient deficiencies and supplementation. You can see micronutrient deficiencies, it can lead to oxidative stress, inflammation, immune dysfunction, defective beta cell, defective enzyme activities, beta cell apoptosis, impaired compensated hyperinsulinemias, insulin resistance, and again as syndrome X, hypertension, type 2 diabetes, dyslipidemia, hyperuricemia. So this is a vicious cycle of micronutrient deficiency leading to oxidative stress and then to diabetes. So how do this micronutrient lead to diabetes? So all these deficiencies lead to activation of insulin receptor phosphatases and defective tyrosine kinase activities, and they are the biggest culprit in causing the diabetes. So vitamin D in diabetes, it is also prone to cause it can be autoimmune dysfunction of pancreatic beta cells, or there is impaired sensitivity on glucometabolism. And this autoimmune destruction of beta cells can lead to type 1 diabetes, and immune impaired insulin sensitivity can lead to type 2 diabetes. So whenever we see that whenever we supplement vitamin D with calcium, it had a good response, and there was change in fasting plasma glucose by 30 millimole per milligram per ml, and you can see this vitamin D deficient individuals with vitamin D less than 13.9 had highest hazard ratio 2.303 in terms of all-cause mortality and CV mortality. So what are the causes and effects of malnutrition in elderly? You can see poor immune function, dysregulation, appetite and thirst, sensory changes, and reduction in gastric excretion. So all of these are the reasons for the malnutrition in elderly: depression, polypharmacy, injury, falls, bone fractures, disability, urinary incontinence, cardiovascular disorders, cognitive decline. There are few malnutrition screening tools like malnutrition screening tool, mini nutrition assessment, SNAC questionnaire, MUST questionnaire. So all of these are used in our OPDs and in our wards to look for the malnutrition in the patients with diabetes or without diabetes. So there are a few goals of malnutrition therapy. First of all, the biggest goal is the healthy full eating patterns with variety of nutrient-dense foods and portion sizes. Second is the individual-based nutrition therapy, the pleasure of eating to maintain pleasure of eating, and to go for the practical tools. And remember one thing, one size doesn't fit for all. You have to go with the different sizes of all patients. And so for type, we have to achieve this plate method of changing the plate from non-starchy vegetables, one half of the plate, and other plate will serve, one half will serve protein-rich foods and grains and starchy foods. So as a take-home message, the nutrition therapy is recommended for all individuals with diabetes as a necessary component of treatment plan. In type 2 diabetes, there 3 out of 4 patients are mostly obese and overweight. While in type 1 diabetes, the patients are underweight. The older individuals are at high risk of undernutrition due to anorexia, weight loss, altered taste, smell, swallowing difficulties, and function impairment. And they are high risk of nutrient deficiencies. And it has been seen that vitamin D patients, the diet in vitamin D and low in vitamin D and vitamin B have been a biggest risk for patients with type 2 diabetes. We have to go for specific assessment of nutrition in elderly as going with the patient medical history, diet plan, areas of dietary intervention, and monitoring the progress. So always I will go with this wording, eat right, move more. So food, glorious food, eat too much and suffer, carbs to be counted, take a bit fiber. Balance your diet with the greens from the racks, avoid oil, ensure 3 meals and 3 snacks. Thank you. Any questions? Thank you, Irvin.
Thank you, sir, for this amazing presentation. But now I am excited to welcome Mr. Sandeep Arora, founder of Udesha Wealth and certified